Good morning to all colleagues. Would you like to thank Dr. Maurice Salama and Natalia Berner for this opportunity. Today I will present my webinar, the second part of immediate implant. In this case, the topic is immediate implant in partial, in full arch rehabilitation, and GBR in the two-all situation of immediate implant. And go to start. I would like to thank to all colleagues in this morning. This is the second part of my webinar. The first part is about scientific background and a single immediate implant. Start on this topic, partial immediate implant and full arch, full case for about immediate implant, and GBR in immediate implant. It's important to highlight that aesthetics are more important in anterior and premolar partial cases. The function is more important in posterior area, while the function and the maintenance are the main objective to be archived in full arch rehabilitation. And now I will start by proposing the following question. Which is the correct distance between teeth implant and implant? The answer: in the literature there are several papers about this topic, but the most important one was written around the year 2000. The work of Cardaropoulos and co-authors in Göteborg University concerned the peri-implant bone alteration related to inter-unit distance. A 3-year retrospective study indicates a lower height of the bone crest in areas with an inter-implant distance of less than or equal to 3 mm as compared to areas with greater than 3 mm between the implants, and suggest that this difference may be the result of lateral bone loss at the implant. The studies of Traini and Piatelli demonstrated that there was a direct relationship between inter-implant distance and the vascularization of the inter-implant bone. They showed that the presence of a more blood vessel in 3 mm group is another indication that 3 mm distance is preferable for contiguous implants when compared with 2 mm. Earlier internals latest studies showed that it's possible to insert platform switching implant at a 2 mm distance between them, achieving the same results as inter-implant bone crest height of no platform switches once inserted at 3 mm distance. The famous studies of Dennis Tarnow in 2000 showed that the effect of inter-implant distance on the height of inter-implant bone crest. The authors demonstrated that 3 mm inter-implant distance allowed for bone peak inter-implant preservation, while it was not preserved when the distance was 2 mm. And the same authors, in another studies in 2003, showed the relationship between vertical distance from the crest of bone to the height of interproximal papilla between adjacent implants. And these studies emphasized the great caution used when placing two implants adjacent to each other in aesthetic zone. In most cases, the mean height of tissue of papilla between the two adjacent implants was 3-4 mm, with a range of 1 to 7 mm. The results showed that when the measurement from the contact point to the crest of bone was 5 mm or less, the papilla was present almost 100% of the time. When the distance was 6 mm, the papilla was present 56% of the time, and when the distance was 7 mm or more, papilla was present 27% of the time or less. And you can see the alveolar bone level maintenance in implant therapy done to my mother 20 years ago on a single implant between two teeth, and in contralateral sides another case with a partial restoration with the two implants with the distance of 3 mm. Now I will talk about the decisional criteria in immediate implants in partial and full arch cases. And now I'll start with the digital planning. In the digital planning is very important. In partial and full case, digital planning is the most important aspect to plan for the best position and for the prosthetic guided implantology. In commerce, we have more diagnostic and digital planning for implants therapy. And then now, it's essential to use if you want to make an high level implant therapy. The flapless, whenever possible, is another important aspect. The flapless implant insertion in immediate implants prevent damage to the cortical bone and improve the vascularization of the cortical vestibular. The use in this case of Bennett 2, for example, prevented this damage. The Bennett 2 provides gentle, simple extraction of root, and the damage to soft tissue and soundering bone is minimized. Because Bennett 2 make an extraction purely with an axial traction. Automatic extraction is the most important aspect of bone preservation, especially the vestibular cortical bone preservation. An automatic extraction using pencil surgery and very thin periotome is absolutely indicated. The vestibular bone maintenance. As we have seen in the previous webinar, the maintenance of the vestibular bone is extremely important in order to optimize perfect healing in immediate implants and to have an high predictability of a perfect osseointegration and to archive a perfect final prosthetic results. Furthermore, the maintenance of a vestibular cortical bone allows for a more stable cloth and an ideal container for a bone substitute. The palatal-lingual implant insertion allows more space to insert a biomaterial to contrast the vestibular bone resorption as shown in Araujo and Linde studies in 2005. As you can remember from my last webinar, part 1. The vestibular cortical bone at 8 weeks after root extraction have more bone resorption than palatal-lingual cortical bone. Primary stability. With the new implant motors, the presence of graphic insertion and the osteal module form to record the stability based on the resonant frequency take us the possibility to look immediately and to archive the insertion torque and the implant stability. This is very important in immediate implants when the implant stability is often given only a few millimeters in apical bone preparation and when we want to make an immediate loading. The gap filling and soft tissue augmentation with a connective tissue graft. The gap filling with the biomaterial enables to contrast the vestibular bone resorption, as showed in Araujo and Linde studies in 2009 and in 2011. You can see the old picture of my last webinar where it's possible to see a bone insertion in the gap and show the placement of bios collagen for extraction soaked make counteract post extraction ridge reduction. Immediate loading when you have a good primary stability. And when we have a good primary stability, an immediate loading is possible to improve aesthetic, resulting in an ideal psychological effect. It's very important in aesthetic area. And now I will now begin the discussion on partial immediate implants. In the first case, we can see all the operative indication in an immediate partial case. In this case, with speed TX implant, a gentle extraction, a palatine insertion, filling the gap, and 3D reconstruction of a crestal and the vestibular bone to optimize healing in prosthetic guided immediate implant therapy. You can see after 5 years the perfect healing of the bone and the soft tissue. When we have a massive destruction of a crestal bone, a perfect insertion is fundamental in areas with good alveolar bone. And it's also important to use a pink ceramic artificial flange to have a small form teeth to meet the demands of the patient. In this case, this is an old patient, female, and he asked me a very small form teeth, as the teeth he had when he was young. In this case, we have extracted an hopeless teeth of this patient and finalized with a partial bridge in the upper jaw and with an overdenture on locator in the lower jaw. After 6 months, you can see the perfect healing, the soft tissue and the bone. The immediate implant therapy is possible and highly recommended in old patients when they haven't got any serious metabolic disease. In this case, a female 78 years old was extracted an hopeless 2.4 and 2.5 teeth with massive bone resorption and the periapical infection. You can see the massive destruction, the massive vestibular bone destruction, and the apical pathology. After a flap elevation, a gentle extraction and perfect debridement was made. Next, begin the implant preparation with a piezosurgical inset with the palatine duration. Make a 2 mm under the bone level insertion of noble active NP implants, healing abutment, and genose bone substitute in the gaps and the extraction area. So we can make a 3D alveolar crescent extraction and GBR with the slow resorption, membrane, creos, noble biker. In the end, we have a big quantity of bone substitute covered with an elastic loss resorption membrane fixed with titanium pins. We can see clinical aspect, and X-ray after the therapy. In time 0, 4 weeks after. 4 months after, a prosthetic finalization with a bridge in porcelain and fused to metal cobalt crown. This is a try-in, and this is the final bridge. And after 5 months, we can see a fantastic aspect of the crestal volume and the pink healed fibromucosa. This is the aspect in pre-surgery, pre-operatory, and after 5 months. And this is X-ray. In partial more than in full cases, the three-dimensional crestal augmentation is important, very important, because we have a natural teeth with a natural bone volume near the rehabilitated area. In this case, we can see how an old extraction had massively resorbed the vestibular cortical bone in 1.4 area. After opening a flap, we can see the resorption areas before and after the implant preparation with the palatal direction. The self-tapping Nobel Active 3.5 narrow platform implants have been inserted, and the vestibular cortical bone has been three-dimensional reconstructed with the BIOS collagen and completely covered and protected with a resorbable collagen membrane. The flap was moved coronally after vestibular periosteal incision and sutured in crest with a 40 PTFS suture and with an 70 monofilament suture for vertical relaxing incisions. At 2 weeks after, you can see an augmentation. 4 months after, we can observe perfect healing and regeneration of a crestal volume. A comparison, time 0, after 2 weeks. And after the 4 months, we can see the amazing crestal volume augmentation. Comparison, time 0 after extraction, and 4 months at the time of the second surgery. Note the perfect horizontal regeneration. At the Batman connection and in the second surgery with a plastic caps for protection and flap suturing. And the X-ray aspect, pre-operatory, and the 6 months after. Therefore, in partial case, prosthetic guide implants with GBR to attain a natural aspect, the volume of the dentulous crest. Now I will show a paradigmatic case, monolateral edentulous patient. He is a male, 70 years old, and is extraction 1.3, healing soft tissue guided healing soft tissue and a guided drilling, a Nobel Active MP narrow platform implants, crestal sinus lift, and 3D reconstruction crest with GBR. In CBTC, we can see only 4 mm thickness. Then narrow platform implants and GBR for over there resorbed and thin crest is recrested. Therefore, it is necessary BIOS bone substitute and a creose membrane resorbable fixed with a pin for make an horizontal GBR and a transar crestal sinus lift with a collagen and BIOS collagen for to eye the sinus. The sutures, 70 vertical relaxing incisions, and FI0 PTFA, horizontal incision. The second stage, 4 months after, a connection of multi-unit abutment and a connected tissue bilaminar graft for improve, for augment the soft tissue. After 6 months, are reinforced provisional bridge cobalt chrome and composites with the anevoid pontic. The aspect of a regenerated crest and X-ray or regenerated area showed a big augmentation. After only 6 months, we can see an amazing bone and fibromucosa regeneration. And it's very important in this case because he have a big crest in the nervy tooth. And 1 year after, it's possible to screw the definitive bridge, Procera ZIRSAM, and the Procera implant bridge ZIRSAM. This case, ceramist is a friend of mine, Roberto Canales from Rome. A comparison after 1.5 years, frontal aspect, and lateral occlusal aspect, contralateral, and left and right lateral and occlusal aspect. And the last but not the least, full arch immediate implant, all on 4 or all on 6 usually. In order of perfectly insert the immediate implants, in addition to the digital planning with C-implant and the complex software for guided surgery, this analytic guide, similar to Malo guide, modified with the indication of the inclination for whomever wishes to insert tilted implant at 70 or 30 degrees might be used. And then on some clinical case. Full arch immediate implant. This is a female, 69 years old. This patient wanted fixed prosthetic, yet the presence of these destroyed elements poles are not strategically important. Therefore, they were delicately extracted, and 6 noble speedy noble biocare implants were inserted, filling the residual socket with bone chips derived from drilling. In the same day, an immediate loading acrylic metal reinforced total bridge screwed on multi-unit abutment was inserted. 4 months after the immediate provisional loading, we take the impression and performed at the framework of a porcelain fused on metal bridge in cobalt chrome ceramic. Note the perfect bonus of tissue healing and the aesthetic integration of the bridge. And a good freehand insertion. Another case, full arch immediate implants, female, 65 years old, immediate loading and GBR with anchor bone, full arch all on 4, and the noble Procera zirconia bridge with a single desilicate crown screwed on multi-unit abutment, straight diagonal, 70 degrees. We can see the 4.3 root fracture and the massive bone resorption. And then we have no more bone on the alveolar nerve. In this case, the only solution is an all-on-4. And in this case, tutestration all-on-4 with tilted insertion for the distal implant and immediate abutment connection and immediate loading. 6 months after provisional bridge, we can see a very good healing And so we made an impregnable permanent impression with the pickup, and after the technician take us an wax try-in bridge, and after try-in over the zirconia Procera implant bridge. And then we made a Procera implant bridge with all the silicate individual crowns screwed on 4 implants. Clinic and X-ray view, and you can see a Nobel Active NP fixtures, multi-unit abutment, Nobel Procera zirconia implant bridge, pink ceramic creation CT, and the silicate AMAX press crown. It's also possible to perform immediate loading after immediate implants with no self-tapping implants, for example with the Straumann bone level implants. Now it's simple with the Straumann bone level tapered implants self-tapping. 4 months after, noted a perfect healing. The success rate of the all-on-4 method is extremely high, even if the statics refer to all-on-4 using Malot approach that requires the absolute respect of a clinical codified protocol. These are Malot groups result in 2003. And here we can see the studies of Agliardi and Malot in 2010 with high success rates with all-on-4 technique. And finally, I would like to discuss an ever more complex therapy, the insertion of more single immediate implants in aesthetic area with the use of single crowns. This patient is a woman, 60 years old, aesthetic and functional problems, advanced and complicated periodontal disease, parafunction, and loss of vertical dimension, vestibular and lateral aspect. Occlusal aspect, note the massive abrasion of the palatal face of the central incisors. You can see the X-ray where it's possible to see an advanced complex periodontitis. In the CBCT aspect, you can see the massive bone resorption around the central and lateral incisors. In the periodont chart, we can see a more depth pocket, especially in 3.1, 2.6 distal, 3.7 and 4.7 mesial and lingual. The periodontal therapy is non-surgical with the full mount scaling root planning and ritual power area polishing, and surgical and guided tissue regeneration with amelogenin and bone substitute on 4.7, 3.7, and 2.6. The surgical therapy is an astration of 1.2, 1.1, 2.1, 2.2 alveolar circuit preservation with bios collagen, and implant therapy and a guided surgery implant safe guide Astratec implant system AV slave-on drill, and immediate implant with the Astratec implant system 3.5 for 11 in the lateral, and Astratec implant system profile 4.2 conical for 11 in the central incisors. We can see the high difficult project with simple software diagnostic and the guided surgery. And here we can see the difficulty in performing freehand surgery in this case. We cannot make a mistake. In this case, in immediate implant and in sloped crest, the use of Astratec profile as a sloped implant, one new implant generation, is highly recommended. And we can see the perfect digital project. With surgical guides make after the digital project with the stereolithography technique, it's possible to make pre-surgical provisional crowns, screwing in, and to make inferior tabletops in composite to augment the vertical dimension. In central incisors, the project is very difficult, flapless post-extractive area, because the residual anatomy showed the possibility to use a new Astrotech Profile V. In this case, it's particularly suitable. This is a pre-visualization of Astrotech Profile V Conical 4.2 411 in digital implant project. Now we can see a short video about immediate implants guided surgery with implant self-guides and immediate loading. A surgical guide was created to allow for the perfect insertion. In this case, it's possible with the surgical guide to make a pre-surgical provisional crowns. A surgical guide was created to allow for perfect insertion in respect to distance, depth, and the correct inclination of 4 post-extraction implants. As we have seen, the remaining bone residual exclusively consists of the basal bone. After a traumatic extraction and the careful cleaning of the socket, the surgical guide is accurately positioned to the dental support. Sites are prepared with the guided drills in the sleeve of the surgical guide and by their built-in sleeve in order to allow for single-handed milling. The prepared sites after the drilling, the perfect drilling with this sleeve on, in the anterior is necessary to use a conical drill. This is an 3.6 Astra Tech implant system, and the prepared sites are largely filled by a biomaterial to contrast the vestibular bone resorption. Then the implant that will have the vestibular notch for 3.6 Astra implant system and the Palatine for Astra Profile implant system are placed. In this case, I insert gently with the hands, and after with the handle screwdriver and after the insertion of the implant, screwing the provisional abutment, and we can fix the crowns with the light cured composite flow. They are then carefully polished and screwed on the implants for immediate loading, function, and to return an happy smile. In this case, it's necessary to have a big and fantastic polishing. In this case, I overcorrect the defect, and after the polishing, the provision are screwed on the implant. The healing after 1 month it's possible to see the healing after 1 month and the situation pre-surgery with an X-ray and only after 1 month. The X-ray where you can see the perfect implant insertion and the perfect healing of the bone. 6 months after, we can see the level of fibromucosa as being lower than the beginning. The soft tissue aspect and the impression capping, and impression with impregum and permadyne light. Definitive WhatsApp and a button-com project of the laboratory, and the digital project of the individual abutment with Atlantis. The healing and the changes of the soft tissue time 0, 1 month after, and 6 months after. And in time 0, 1 month, and 8 months after. Now you can see the titanium individual abutment Atlantis at the second provisional crowns, and the definitive abutment screw with the crown 10 months later, 6 months after, and 10 months after. The level of the issue, soft tissue, 6 months after, and 10 months after. And the X-ray, 1 month after, and 10 months after. Comparison, 10 months after, in other persons. And the success criteria. The success criteria, when we talk about the success criteria, it's important to use the Abramson criteria based the Albrechtson criteria based on X-ray implant aspect, but it's very important to use the objective aesthetic criteria in single immediate implants rehabilitation and partial cases too. The white and pink aesthetic score developed by Bals and co-authors in 2009. In the white aesthetic score, the aspect of the crown is very important, as in the pink score. The anatomical aspect and the soft tissue harmony is evaluated with a score. More closer than the score is to 10, more we have a perfect implant therapy and a natural B-emulation. Advantages and disadvantages and the disadvantages showed by Kirinen and Jomi in 2007. The important outcome is implant survival data seem similar for 3 groups. Data on implant success are sparse for immediate and early placement, but the immediate implant show short treatment time, reduce the number of surgical procedures, bone substitute to fill to void where applicable, and it's important to have a primary stability to archive the apical lateral stabilization, and ability to remove all residual infection. In conclusion, positive and negative aspect. And the positive aspect is less number of surgeries, less treatment time, less patient discomfort in immediate loading, better tissue healing, and psychological help in thought loss. The negative aspect in a surgical technique, in these surgical techniques, that requires experience, science, and art, good quality of bone for implant primary stability, and aesthetic area, we have a higher risk. And a take-home message is important an automatic extraction ever, a palatine direction drilling and implant insertion, implant position 2.53 mm lower than the cementum element junction of nerve teeth, regeneration with biomaterial and connective tissue graft in aesthetic area is very important, when we have no high torque insertion, is no indicated an immediate loading. Thank you to all for your attention, and thanks to Maurice Salama and to all Dental XP for this my opportunity.